Welcome to our training on population needs. This is a fairly long lesson, so please make sure that you have time to complete it and also that you have the necessary supplies with you in order to complete a long lesson, such as beverage and a snack. This lesson talks specifically about various special populations in substance use and mental health treatment. In order to complete this lesson, please remember that after viewing this presentation, you will be required to complete the attached quiz with a passing score of at least 70%. I hope that you enjoy the training. Over a number of years, a number of subgroups have been identified as special populations for the purposes of planning and evaluating the national system of treatment for mental health concerns and substance use disorders. Through the years, barriers to accessing and successfully completing treatment were identified for a variety of such groups. Efforts were initiated to provide funding for separate groups or to make sure that generic or mainstream programs were structured so as to provide appropriate outreach and treatment. Emphasis has been placed on developing treatment strategies that would be delivered through separate treatment programs, employing clinical and administrative staff from the affected group whenever possible, or with special training for staff of mainstream programs in understanding the environment in which the persons that they are treating have functioned and developed their concerns. Throughout the history of its funding of specialty programming, the federal government has emphasized that there are certain populations or subgroups that must receive special attention because of their unique characteristics and their inability to receive appropriate treatment within what might be called generic treatment programs. The term special populations takes in a wide range of categories, many of which do not truly make up a self-identified group. Yet the concept is still seen by those in the field as instructive for designing and implementing treatment programs in instances in which there is information on commonly shared characteristics that are thought to have relevance for treatment attraction, retention, and maintenance. The concept has remained important at the state and local service delivery level. The states report that they are continuing to provide services targeted toward a variety of special populations, even though the federal government no longer requires such targeting. Legislators, clinicians, and researchers recognize the need not only to define, but also to provide culturally relevant treatment for individuals who belong to special populations. Yet, there is little consensus about what such treatment entails, for whom it is specifically designed, and actually what the term special populations means. In this lesson on special populations in mental health and substance use disorder services, we will individually and separately discuss the unique issues for the populations that are listed here on this slide. Individuals who have co-occurring disorders, children, the elderly, individuals with racial, ethnic, and cultural minorities, individuals with physical disabilities. We will address sexual orientation and gender identity issues, criminal justice involved individuals, and finally, homelessness. Co-occurring mental health and substance use disorders are common among individuals who receive behavioral health services, and the presence of co-occurring disorders increases symptom severity, complicates treatment, and leads to poor client outcomes. Thus, to improve treatment for a substantial portion of their clientele, behavioral health providers should deliver services that address the specific needs of individuals with co-occurring disorders. Yet, the provision of co-occurring disorder services remains the exception in most behavioral health treatment settings. At one time, treatment for substance use disorders was considered to be separate from treatment for mental health disorders, and care was delivered at different facilities using radically different therapeutic approaches. As a result, many people who suffered from serious psychiatric conditions never received treatment for their substance use. By the same token, many substance use treatment graduates with co-occurring disorders never received adequate care for their underlying mental health concerns. Today, addiction specialists and mental health clinicians view co-occurring disorder treatment as a unique field in its own right. The U.S. Department of Health and Human Services estimates that severe psychiatric disorders like schizophrenia, bipolar disorder, and schizoaffective disorder affect up to 5% of Americans, and that as many as 1 in 5 Americans struggle with mental illness at some level. Within that group, approximately 7 million also suffer from substance use disorders. Integrated treatment for co-occurring disorders is the key to protecting this group from the poverty, illness, isolation, incarceration, and homelessness that often affect individuals who have co-occurring disorders. In recent years, studies of rehabilitation programs for people with co-occurring disorders have shown that integrated treatment is the most effective approach. Combining strategies from the field of mental health and substance use treatment can lower the relapse rate, reduce the number of suicide attempts, and foster long-term abstinence, according to research gathered by the Substance Abuse and Mental Health Services Administration. Treating substance use disorders and co-occurring mental health disorders at the same time is important for several reasons. First of all, integrated recovery plans are designed to overcome the negative side effects of many mental health disorders, such as reduced attention span, a low level of motivation, and a fear of socializing with others. Medication therapy may be more effective when the plan addresses both the mental health disorder and the substance use disorder. In co-occurring disorder treatment, the traditional hesitations about prescribing medications are no longer an issue. Additionally, treating substance use and mental health disorders at the same time helps service providers address an individual's unique relapse triggers, such as depression, mood swings, or panic attacks. In 2001, Dr. Kenneth Minkoff, a pioneer in the field of co-occurring disorder treatment, published an article in Psychiatric Services outlining the best standards of care for co-occurring disorders. The standards that Minkoff proposed included: number 1, welcoming clients with co-occurring disorders into substance use treatment programs instead of excluding them because of a psychiatric condition. Number 2, giving the substance use disorder and the co-occurring psychiatric disorder the same level of attention and care during the service process. Third, ensuring that care is provided by a treatment team that is trained in addressing co-occurring disorders. Fourth, assessing each client for mental health disorders as early in the service process as possible so treatment can begin promptly. And finally, treating all clients with dignity and respect, even if they are in the midst of a mental health crisis or are acutely intoxicated. There are a couple of issues that I want to discuss specifically related to case management services with individuals with co-occurring disorders. First, it is critical that the case manager has the ability to complete an assessment for both mental health and substance use concerns. For this assessment, we're not talking about completing a diagnostic interview. Rather, we need to assess the possible impairments for the person as a result of both problems and identify the person's strengths that can be used to manage both of the problems. The assessment should also include an assessment of the individual's personal goals. Since co-occurring disorders can create significant impairments and disruptions in a person's life, we may have to work hard with the client to identify exactly how they want their life to be different. It is important to not allow our own beliefs, experiences, and expectations of persons with co-occurring disorders to limit our vision for what is possible for the person. Remember, recovery is not only a possibility, it is a reality, even for individuals with co-occurring disorders. Next, we need to remember when we are doing service planning and referrals that integrated mental health and substance use treatment is the preferred treatment for co-occurring disorders. Depending where you are in the state and what services are available in your community, integrated services may or may not be available. If they are not available, it will be important to identify treatment for each concern and to work deliberately to coordinate between the providers for those services. Finally, many individuals with co-occurring disorders may be very difficult to engage in services. In the words of Jim Valvano, don't give up, don't ever give up. There are many reasons that the person may be hesitant to engage in services. They may have had problems with services in the past. They may not believe that services can be helpful to them. They may not even believe that they need any kind of services or that they want to change anything in their life. We want to use everything that we previously identified in the separate training about engagement to begin to build a professional relationship with that person. Any benefit for that person will come only after we have built that relationship. The next special population that we want to discuss is children in the behavioral health system. Working with children has some significant differences than working with adults. First, when working with children, involvement of the family in services is not just an option, it is a requirement. The most significant influence in a child's life is their family, and they must be included in any services that we provide. There is a section regarding family involvement in the collaboration training. While talking about family involvement, we also have to talk about confidentiality issues when working with children. Under Florida law, a child 13 years of age or older may consent to mental health emergency evaluation or crisis services, but parental consent is required for subsequent services. However, for substance use treatment, a minor may consent for services. Where this issue may get confused is determining what information about the child's treatment does the parent have a right to access. Clearly, parents have the right to consent to any medical treatment for their child, which includes the prescribing of medications. But is a parent entitled to know what you talked with the child about during your meeting with the child? Legal scholars still have differing opinions on this question. The safest way to avoid any of these problems is to make sure to include the family members in any services that you provide. The second largest influence in a child's life is their school. Again, in the lesson on collaboration, we discussed the importance of having other professionals as part of the service team. The difficulty for us comes when there is a need for us to understand education-related issues when we have not been trained in these. Many behavioral health care workers feel out of place in school settings So school personnel may need to be involved in the service plans of the children that we serve. Another major issue in children's behavioral health services is access to care. National estimates are that 1 in 5 children, or about 15 million children, have a recognizable behavioral health disorder that significantly impacts their functioning. These national estimates go on to state that only 1 in 5 of the children with these behavioral health disorders receive any treatment. When we do the math, that means only about 3 million children are receiving services, and 12 million who have a recognizable disorder are not receiving treatment. The behavioral health needs of children far outstrip available resources. So in some situations, we may find that some of the services that a child may need may be difficult to access. Another special concern in working with children is making sure that we have the education and experience to work with children. Children are not just smaller adults. They have different cognitive processes, and values and goals will be much more fluid than they would be for adults. Additionally, having training and experience working with children does not necessarily qualify us to work with families. We also need training and experience in that dimension if we are going to work with children. And finally, there is a simmering controversy regarding the use of psychotropic medications with children. That controversy is far beyond the scope of this presentation, but if you are interested, I encourage you to do some additional research. We could probably go on and on about the special needs of children, but I don't think either of us wants to still be listening to this training tomorrow. Luckily, the issues related to children are specifically addressed in other trainings in this curriculum. The World Health Organization defines health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Because mental health is essential to overall health and well-being, it must be recognized and treated in all Americans, including older adults, with the same urgency as physical health. For this reason, mental health is becoming an increasingly important part of the public health mission. In fact, the mental health of older Americans has been identified as a priority by the Healthy People 2010 objectives, by the 2005 White House Conference on Aging, and in the 1999 Surgeon General's report on mental health. The massive growth of the population of older adults that will take place over the next quarter century has fueled great concern about the future solvency of the Social Security system and of Medicare. Less noticed is the fact that approximately 20% of older adults have diagnosable mental disorders in any given year, and that accordingly, as the population of adults 65 and older grows from 35 million to 70 million, the number of older adults with mental health disorders will grow from 7 million to 14 million. The critical question is, will services be available to meet their mental health needs? I ran across this slide from the U.S. Census Bureau as I was preparing this presentation and just had to share it with you because of its dramatic visual impact. In just 100 years, the population of the United States will have changed from a pyramid structure to a pillar or column structure. In just 40 years from now, there will be as many people over the age of 65 as there are people aged 20 to 40 or who are aged 40 to 60. This change in population dynamics should not only be alarming, but should also inform us of the need to prepare to meet the mental health needs of our aging population. There are reasons for concern. The current system does not do enough to help older adults with mental disorders to remain in the community. It does not provide adequate access to services. Generally, services are not designed to respond to the unique needs of older adults. Mental health, and aging services are excessively fragmented. There is limited capacity to serve cultural minorities who will grow from roughly 15% of the elderly population to over 25%. In addition, most older adults with mental disorders who get treatment get it from primary care physicians, who usually do not provide minimally adequate care, while those who get treatment from mental health professionals are more likely to get minimally adequate care. Many do not because there are so few mental health professionals with training regarding older adults. Many older adults with mental disorders turn to family, friends, clergy, and community organizations who sometimes are helpful, but who are, of course, not prepared to deal with complex mental or substance use disorders. The most common mental disorders of the aging population are anxiety and depression. Approximately 15% of older adults have anxiety and/or major depressive disorders, which often contribute to severe isolation and inactivity. These symptoms, in turn, often cause deepening anxiety and depression, a vicious cycle that is difficult to break. Depressive disorders contribute to the high rate of suicide among older adults. Overall, adults 65 and older are 50% more likely to commit suicide. This rises to 600% in white men 85 and older. Many people with anxiety and depressive disorders do not go to mental health professionals for help because of a sense of shame and embarrassment, because of ignorance about mental illness and effective treatment, and because they often cannot or will not leave their homes. For this population, it is critical that the mental health system be more mobile, that mental health professionals go to people in their homes and community settings where they are comfortable rather than waiting for them to come into the office, and that there be better linkages between mental health and primary health care and home health care providers. Older adults with mental disorders almost always have chronic physical conditions for 3 reasons. Most older adults, including those with mental disorders, develop chronic physical conditions such as hypertension, arthritis, diabetes, and others. Some mental illnesses create greater risks of developing physical conditions. For example, obesity, high blood pressure, diabetes, and heart conditions are associated with serious mental illnesses. And finally, many physical illnesses have psychological correlates. People with cardiac disease, dementia, Parkinson's disease, and other serious illnesses are at greater risk of anxiety and/or depressive disorders and of cognitive impairment, sometimes of psychotic proportions. For this reason, integrated treatment of health and mental health conditions becomes increasingly important as people age. This can be done in several ways. First, incorporate mental health professionals into primary care practices. Second, enhancing the ability of primary care providers to identify and treat mental health disorders. Third, incorporate mental health expertise into home health services. Fourth, improve linkages between mental health and specialty services. Fifth, provide telephone consultation and services. And finally, 6, incorporate health and mental health services in community settings, such as senior centers and social service programs in naturally occurring retirement communities. In response to prejudicial views of older persons that pervaded the youth-oriented culture of the 1960s, a gerontologist named Robert Butler coined the term ageism to reflect the similarity of these prejudices to racism and sexism. He perceived ageism as a way of pigeonholing people and denying older adults the opportunity of being individuals capable of adapting unique ways of living their lives. Within the U.S., negative cultural attitudes toward the elderly have pervaded our social institutions and our individual psyches. A number of studies have been published over the last 30 years that have demonstrated the existence of negative attitudes toward older adults among mental health and substance abuse professionals. Older adults were described in one study as being rigid, having difficulty learning new material, and lacking the energy and resilience for therapeutic growth. Another researcher found attitudes among workers that included the beliefs that depression is a natural consequence of old age, and that old age is a phase of life associated with less satisfaction and diminished personal growth. More disturbing, researchers also found that providers were less interested in treating older adults with suicidal tendencies, and the belief that suicidal tendencies among older adults were seen as logical and normal. Finally, the researchers identified the phenomenon of self-ageism, where older adults accept the societal prejudices as an accurate perception of who they are and what they can do. When we're working with an older adult, we need to be very aware of the presence of these prejudices. We need to actively advocate for effective treatment services. When we identify deficits that may be related to aging, we need to creatively develop plans to manage these deficits, rather than giving up and saying, well, it's just old age. We especially need to be aware that the persons we serve may have very limited views of themselves and their abilities. If we accept these views, all of our work will be very limited. If we can reject these views, we may find enormous talents and abilities within the person that person was hesitant to express. The special needs in human services related to culture, race, and ethnicity are so pervasive and widespread that an entire field of study called cultural competence has been developed to address those needs. I know that it may sound old, but the seminal work related to this issue was published in 2001, titled Mental Health, Culture, Race, and Ethnicity. A copy of this publication is provided for you in the lesson media section of this lesson. While a consensus about what constitutes a disparity has not been reached, here we will use the definition that a disparity is a difference in healthcare quality not due to differences in healthcare needs or preferences of the patients. Disparities in mental health exhibit a decidedly different pattern from disparities in health. In general, minorities have poorer health and health outcomes than do whites. However, many studies show that members of minority groups have either a lower or equivalent rates of mental health disorders when compared to whites. However, those minorities who do become ill tend to have more persistent disorders. Although the rates of disorders are not higher among minorities, psychological symptoms do tend to be higher among minorities and the poor. So we can conclude that there are few disparities in mental health diagnoses. However, when we turn our attention to mental health care, significant disparities do exist in both access to care and utilization of care. Racial and ethnic minorities have less access to mental health services than do whites, are less likely to receive needed care, and are more likely to receive poor quality care when treated. Disparities exist in access to and use of mental health services for ethnic minority individuals. Furthermore, during the past decade, efforts to eliminate those disparities have not been successful. While mental illnesses do not discriminate, our mental health care system does. Fewer than half of all adults in the United States who experience a mental health disorder receive treatment. But individuals belonging to various racial and ethnic minority groups receive treatment at significantly lower rates than whites, though the rate of need for services may not be that different. How do they compare? On average, by race, groups experience mental illnesses at varying, but sometimes similar rates. However, African Americans receive treatment at a 50% lower rate than whites, Hispanics or Latinos at a rate of 60% lower, American Indian Alaskan Natives at a rate 40% lower, and Asian Americans at a rate 70% lower. Some of the critical barriers faced by ethnic minority communities include the following. First, less access to treatment. Access to treatment refers not just to the availability of mental health services, but also includes logistical barriers such as transportation, childcare, obtaining time off from work, and other similar items that restrict an individual's ability to get to treatment services. Number two, individuals are less likely to seek treatment. One attitude regarding mental health services prevalent in 180 individuals from vulnerable populations in a 2014 study indicated that these individuals did not believe that mental health treatment would help them. There may be a history in communities where the communities have not experienced mental health treatment as particularly helpful. Third, poor quality of care. Many factors may contribute to poor quality care, including less participation in treatment decisions and not understanding a diagnosis or treatment. There may be limited resources, especially in poorer communities. Number four, higher levels of stigma. Spiritual, religious, or cultural beliefs about mental illness vary among groups, and a lack of accurate information can inhibit persons in need from seeking treatment, specifically because of their own cultural beliefs. Number five, our mental health treatment system is culturally homogeneous. Ethnic minorities are underrepresented in the provider population, who often know little about the cultural values and backgrounds of the patients they are treating, or the traditions of healing and the meaning of illness within their cultures. Number six, racism, bias, or discrimination may limit accessing care. Low income and ethnic or racial minority individuals may be hesitant to engage in mental health care because of fear or mistrust due to historical persecution and racism within the mental health care system, which in the past has led to misdiagnosis and inappropriate treatment. Number 7, language barriers. Mental health professionals that can provide direct care in languages other than English are lacking in many areas, even where minority group populations whose first language is not English are high. And finally, number 8, lower rates of health insurance. Poverty is not only a contributor to mental illness, but lack of money is often an important reason provided by many individuals belonging to minority groups for not seeking treatment. While our national system of behavioral health care has been unsuccessful in addressing the barriers identified in the previous slide, we will not be working with the national system. We will be working with one individual at a time. When we are working with a person who identifies as a racial, ethnic, or cultural minority, it is critical that we attempt to understand the meaning that they give to the problems that they are experiencing, as well as their experience with and expectations of the mental health system. This individualized approach is the backbone of the principles of cultural competence. There is another lesson in this curriculum that specifically addresses cultural competence, so we won't go further into those issues at this time. Increasing attention has been paid to how people with mental health support needs and people with physical impairments experience services. However, policymakers and service providers tend to overlook individuals who fall into both of these categories. People with physical impairments associated with conditions such as cerebral palsy, multiple sclerosis, or spinal cord injury are as likely as the general population to experience mental health problems, and indeed may be more likely to be users of mental health services. Possible reasons for this include higher rates of poverty and unemployment, which are themselves associated with poor mental health, the mental health legacy of the greater risks of abuse experienced by disabled children, and some indications that people with mental health support needs are more likely to become physically disabled as a result of accidents or attempted suicide. There is also evidence of a link between poor physical and mental health, and increasing acknowledgement that long-term mental health problems are correlated with conditions such as heart disease and diabetes. Yet there has been little recognition that such conditions can result in physical impairment, such as mobility difficulties, and the implications of this for mental health services. Among those commissioning physical disabilities services, there has been little recognition that some service users also have mental health problems, or the consequences of this for meeting the individual's needs. Within both mental health and physical disability services, there have been pressures for interagency and interdisciplinary work. However, these policy developments have not fully recognized that people who use services may have both mental health needs and physical impairments. Jenny Morris recently published research where 83 people who have physical impairments and mental health support needs returned a postal questionnaire, and in-depth interviews were carried out with 25 of these individuals. The results indicate the special needs that individuals who have physical disabilities have when interacting with the mental health service delivery system. 2/3 of the respondents said they had difficulty accessing mental health services because of their physical impairments. They talked not only of inaccessible physical environments, but also of unhelpful attitudes among staff. Inpatient experiences were often characterized by a lack of physical assistance for even simple things. People commonly found that medication that they needed for their physical impairment was withdrawn upon admission and was not always made available when they needed it. If the medication was needed for pain, this withdrawal and lack of control caused significant distress. Community mental health workers were often unfamiliar with physical impairments and the assistance people required to access services, which could be as simple as help with opening doors, a higher chair, or more appropriate timing of appointments, and these needs often went unrecognized. A number of respondents found that a lack of familiarity with physical impairment among mental health staff resulted in disempowering attitudes. Almost 60% of the respondents reported that medication given for mental health needs had an impact on their physical impairment, while over 40% said medication relating to physical impairment had a negative impact on their mental health. Most reported they had not been warned about these potential effects. Some found medication had a significantly negative impact on their physical abilities, while others found that existing physical impairments meant that side effects, such as weight gain, were particularly difficult to deal with. Few people experienced a coordinated approach by psychiatrists to the prescribing of medication for mental health needs and physical impairment. Regular reviews of the medication also appeared uncommon. An area worthy of mention is tips that all professionals who work with persons with disabilities should keep in mind and practice. Professionals who are mindful of these tips will increase their chances of developing an effective therapeutic relationship and understanding of persons with disabilities. Many of the tips are simply based on common sense and related to the art of treating persons with disabilities with respect and as human beings, the same as anyone else. Some of these tips include: first, being mindful that the expressed negative experiences related to disability are real. Individuals who have a disability may have negative experiences in their life related to those disability, and we cannot minimize these experiences because for the individual, those experiences are real. Second, considering the effects that labels may have on the individuals that we serve. We've talked many times in many of these lessons about the problems that labels cause. This is a person who happens to have a disability. The person is not in any way, shape, or form defined by their disability or any label that is attached to them. Third, we need to treat persons with disabilities as human beings rather than as their disability. Continuing with the idea of not using labels, these are people that we are serving, and we must constantly remember that we are serving the person, the whole person, not just the disability. Number 4, building awareness of our own attitudes and biases which may affect the professional relationships. All of us have our own life experiences, our own beliefs, and these may affect our perception of individuals with disabilities. It's not necessary that we have a certain set of beliefs. What is necessary is that we are aware of our own attitudes and biases and are able to keep these out of the professional relationship. Number 5, we need to be aware of how individuals with disabilities describe themselves. We do not want to use descriptions that we arrive at. Instead, we want to use the language that the individual uses to describe him or herself. Number 6, we need to respect the fact that persons with disabilities know their own bodies and experiences. We don't want to tell an individual what he or she may or may not do, what is possible for them. The individual, him or herself, knows their own body certainly better than we do. Number 7, we want to make sure that we get the necessary training and supervision that is needed to effectively work with persons with disabilities. Number 8, we need to pay attention to the abilities and strengths of persons with disabilities and incorporate those abilities and strengths into the professional relationship. There are a number of lessons in this curriculum that discusses the need to recognize abilities and strengths and bring those into the case management relationship that we have with the individual. And those ideas apply to individuals who have a disability as well as all of the persons that we serve. Number 9, we need to recognize that most persons with disability do not live their life focusing on their disability and limitations. Most persons who have a disability spend most of their time focused on living their lives, and we want to make sure that the services that we provide do not focus solely on the disability. Number 10, we want to identify topics which make us uncomfortable, for example, sexuality and disability, so that we can address these. As I said, all of us have our own attitudes and biases. There may be things that we are not necessarily comfortable with. We need to work with training and supervision to make sure that our discomfort does not limit our ability to work with individuals and their ability to talk about these issues with us. And finally, number 11, we need to be willing to have an open mind to the shared experience within the professional relationship. As in previous lessons or other lessons in this curriculum, we talk about the importance of the relationship. And if we are able to have a person-to-person relationship with the individual with disability that we are serving, we look beyond the disability to the person served. As we begin our discussion of sexual orientation and gender identity and its impact on mental health issues, I think that it's important to get some definitions out of the way. A project funded by SAMHSA arrived at the following definitions. Sexual orientation describes the gender of the person to whom someone is attracted emotionally, romantically, sexually, and intimately. Sexual orientation exists on a continuum and is not necessarily congruent with behavior. Examples of sexual orientation include lesbian, gay, bisexual, or heterosexual. Sexual orientation involves a process of discovery over time. It is not a volitional choice. The term sexual preference is often mistakenly used interchangeably with sexual orientation. But this inappropriate term implies that sexual orientation is chosen. It should not be used. Gender identity refers to the gender with which someone identifies, regardless of the biological sex label assigned at birth. Gender identity is a psychological sensing of one's gender, whereas biological sex refers to biology and includes male, female, and intersex. Examples of gender identity include man, woman, or genderqueer, which means does not identify with any gender label. Gender identity is expressed in a range of ways, such as dress, behavior, speech, and appearance. Non-conforming gender behavior in children can be confusing to everyone and may or may not reflect the person's gender identity or sexual orientation. Transgender is an umbrella term that describes someone whose gender identity or gender expression differs from expectations associated with the sex assigned to them at birth. It is not dependent on having sex reassignment surgery. A person's genital status, whether one has had surgery or not, does not determine that person's gender for the purposes of social behavior, service provision, or legal status. And finally, gender expression is the external representation of one's gender identity through how one presents or communicates their gender to others. Gender expression may be congruent or incongruent with someone's gender identity. It's no secret that being different than other people, whether it means your race, your gender identity, or your sexual orientation, is often a source of stress in our society. People of minority sexual orientations often feel that stress most acutely, and it's no surprise. It wasn't until 2015 that a federal judge ruled that the 1964 Civil Rights Act protects sexual minorities from employment discrimination. In 31 states, there is still no law that protects employment for people who identify as transgender. And employment discrimination is just one issue. Rights surrounding relationships and parenting, using public spaces such as restrooms and schooling, also create stressful situations. Challenges such as the stigma associated with sexual minorities, discrimination, family disapproval, social rejection, and violence are among the factors that can lead to mental health problems. It is increasingly clear that sexual orientation and identity are important factors in understanding health and other well-being outcomes. Although the reasons for this are unclear, sensitivity to the relationship between these are critical for protecting vulnerable people and population. First, want to mention that LGBTQ adults are more than twice as likely as heterosexual adults to experience a mental health condition. The 2015 SAMHSA survey on drug use and health found that 33% of the LGBTQ adults experienced mental illness during the year, compared with only 20% of heterosexual adults. Even among adults with mental illness, LGBTQ adults may experience more serious symptoms. Among LGBTQ adults living with mental illness, 13% had a serious mental illness that substantially interfered with major life activities. The same was true for only 4% of heterosexual adults living with mental illness. Second, LGBTQ individuals are at a higher risk than the general population for suicidal thoughts and attempts. In a recent survey, 48% of all transgender adults report that they have considered suicide in the past 12 months, compared to 4% of the overall U.S. population. And 40% of transgender adults and 20% of sexual minorities have attempted suicide during their lifetime, compared to less than 5% of the U.S. population as a whole. Third, LGBTQ adults have a higher risk for substance use disorders. A recent survey found that 15% of LGBTQ adults had a substance use disorder in the past year, compared to 8% of heterosexual adults. Stigma plays a major role in the increased incidence of mental health concerns in the LGBTQ population. A 2014 study found that LGBTQ people who live in communities with more stigmatizing attitudes die an average of 12 years earlier than LGBTQ people in the least prejudiced communities. Numerous studies have shown that transgender people who experience more stigma and discrimination are more likely to experience mental health problems and suicidality. The situation may be even worse for LGBTQ youth. Transgender youth are far more likely than their non-transgender peers to experience depression, nearly 4 times the risk according to one study. Similarly, LGBTQ teens experience significantly more depressive symptoms than their heterosexual peers. In a 2016-17 survey, 28% of LGBTQ youth, including 40% of transgender youth, said they felt depressed most or all of the time during the previous 30 days, compared to only 12% of non-LGBTQ youth. According to the CDC's 2015 Youth Risk Behavior Survey, 60% of LGBTQ youth reported being so sad or hopeless they stopped doing some of their usual activities. LGBTQ young people are more than twice as likely to feel suicidal and over 4 times as likely to attempt suicide compared to heterosexual youth. The rates may be especially high for transgender teens. According to one study, a third of transgender youth have seriously considered suicide, and 1 in 5 has made a suicide attempt. Strong family bonds, safe schools, and support from caring adults can all protect LGBTQ youth from depression and suicidality. A study published in the Journal of Child and Psychiatric Nursing reported that LGBTQ youth with affirming families reported higher levels of self-esteem and overall health. Youth with the least accepting families were more than 3 times as likely to consider and attempt suicide compared to those with highly accepting families. For transgender children and youth, family and community support makes all the difference. Although research has repeatedly found that transgender children experience mental health problems, including suicidality, at higher rates, a recent study found that transgender children whose families affirmed their gender identity were as psychologically healthy as their non-transgender peers. There are a couple of key competencies that are particularly important in working with LGBTQ clients. First, don't make assumptions. It is important to understand that LGBTQ people are a diverse and non-homogeneous group of individuals. How they experience their sexual and gender identity varies from one person to the next, including their initial understanding of this facet of their lives, what their identity means to them, how they disclose to others, how others respond, and how these individuals react to adversity. LGBTQ people also have multifaceted identities: rural, urban, professional, cultural, ethnic, religious, and these can affect their worldviews and resources. In addition, their reasons for needing services may or may not relate to their LGBTQ identity. For example, the death of a loved one may not relate to a client's sexual orientation. Therefore, we must allow our clients to explain the importance and relevance of each of their identities and acknowledge that they intersect. Let clients guide us as to whether their LGBTQ identity is relevant to their present behavioral health concerns. Second, It is important to understand the mental health and addictions related environmental factors. First, LGBTQ people disproportionately experience one-on-one discrimination in their everyday worlds, such as from friends and family. Indeed, family rejection of LGBTQ youth is linked to higher levels of depression, suicide attempt, illegal drug use, and unprotected sex. Perhaps due to high rates of family rejection, homeless youth are disproportionately LGBTQ. Many resort to survival sex for money, food, shelter, and/or drugs. Partially due to these circumstances, LGBTQ young people are also overrepresented in the juvenile justice system. While LGBTQ youth are only 5 to 7% of the general population, they make up 15 to 17% of youth currently in the juvenile justice system. Regarding substance use, meeting places for LGBTQ people historically have been centered around bars and nightclubs, creating a culture of acceptance of alcohol and club drug use. Although meeting places have broadened considerably in many geographic areas, acceptance of alcohol consumption and drug use remains high, and there are higher rates of problem alcohol and some illicit drug use than for heterosexual people. Rates of smoking are higher as well. Finally, abuse is also more common for LGBTQ people than for their non-LGBTQ peers. This includes verbal taunts or threats, peer bullying among young people, and physical violence. In addition, rates of sexual violence are high, including sexual violence from an intimate partner, particularly for bisexual women and gay and bisexual men. Third, we want to promote resiliency. Many LGBTQ people have supportive people in their lives and positive identity-related experiences. Others have had hardships related to their sexual orientation and gender identities, but through those experiences may have developed a complex set of coping strategies. Through activism, mutual support, and personal growth in the face of adversity, LGBTQ individuals can bring enormous strengths to their communities. As providers, we can help clients identify their unique strengths and resources, as well as encourage them to connect with positive informal and formal peer support networks. Family systems can also be an important protective factor in the lives of LGBTQ youth and adults. While family rejection can result in negative health outcomes, family acceptance can lead to a variety of positive health outcomes. When appropriate, service efforts should include family members of LGBTQ people with the goal of increasing family support and promoting the resiliency of LGBTQ clients. Number 4, we want to create a safe space. To lay a foundation for building a relationship with our LGBTQ clients, there are tangible steps that we can take to help them feel safe and supported, and to get them in the door in the first place. Begin in the physical space where you provide services. You could place LGBTQ specific health resources in your waiting areas. Put a safe space sticker or other affirming symbol on your door. While these measures may seem small, they can go a long way toward making LGBTQ clients feel welcome. For youth, creating a safe space may also mean explaining what you can and cannot keep confidential. It is up to the youth to disclose sexual orientation or gender identity-related feelings or behaviors to others. Disclosing this information to a parent can sometimes provoke negative reactions from the parent and worsen the home situation. so we cannot do so without the youth's explicit consent. If we're concerned about a young person's mental or physical well-being, to coming out or related to identity-related bullying, we can share our general concerns with the parents without mentioning the reason why the young person is in distress. If the parents ask why the youth is feeling this way, we should encourage a direct discussion with the young person. Creating a safe space for transgender clients includes being respectful of their identity. Ask them what words and pronouns they use to refer to themselves, and use those. Help other staff do this as well, including the front desk staff. Fifth, we need to know and refer to appropriate resources. Another way to assure that our services make LGBTQ clients feel safe and affirmed is to create and maintain a list of LGBTQ-specific resources and services. It may undermine our effectiveness if we refer clients to a 12-step program that is not familiar with LGBTQ issues, or worse, is hostile to those issues. You may have to check on the LGBTQ competence of such services or providers yourself. You can also ask other clients who they trust. Making these resources readily available on our website, in our waiting rooms, in our offices, and in service spaces sends a clear and affirming message to our LGBTQ clients. If possible, we should attempt to connect transgender and bisexual clients to identity-specific supports, because these individuals may not feel welcomed or identify with gay or lesbian focus group. If there is no local bisexual or transgender specific resources, supports are available online. Our next special population is individuals who have criminal justice involvement. The numbers are astounding. Although nationwide studies are not available, small-scale studies show the high rate of criminal justice involvement among those who are receiving mental health services. In San Diego, for example, 12% of persons receiving mental health services were incarcerated during a one-year period. Compare that to our general population incarceration rate, which is less than 1%. In Los Angeles, 24% of Medicaid clients receiving mental health services were arrested over a 10-year period. Again, compare that to our national arrest rate, which is just over 3% in a given year. For individuals with serious mental illnesses, it is even worse, with estimates reaching as high as 1 out of 2, or 50%, of individuals with a serious mental illness will be arrested at some point in their life. If we look at the numbers from the other side, the rates are frightening as well. Estimates are that 45% of the individuals in federal prison, 56% of the individuals in state prisons, and 64% of the individuals in local jails have a mental health disorder. Additionally, estimates are that 65% of all inmates in federal, state, and local facilities have a substance use disorder. What we can conclude is that individuals with mental health or substance-related issues are arrested and incarcerated far more often than the general population, and these same individuals are grossly overrepresented in prisons and jails. In 1972, state and federal prisons in the United States held 200,000 people. Since then, the prison population has experienced an unprecedented rise. By 2000, more than 1 million additional people have been added to the nation's prisons, for a total of nearly 1.4 million, or nearly 7 times the number of 3 decades ago. As of 2016, 2.3 million people were incarcerated in the United States. State mental health hospital populations peaked at 559,000 persons in 1955. By contrast, in 2016, there were only 38,000 beds in state psychiatric facilities. 40 state mental hospitals have closed during the past decade, while more than 400 new prisons have opened. As a result, jails and prisons have become the institutions most likely to house the mentally ill. Prisons and jails have always held people who are mentally ill. Given the dramatic rise in the overall incarcerated population, it could have been expected that the number of incarcerated mentally ill persons would also have risen. However, other factors have brought the proportion of mentally ill within the criminal justice system to a vastly higher level than their proportion within the general population. Mental health disorders among prisoners are estimated to be at least 5 times more prevalent than in the general population. Much of the problem has arisen from deliberate policy decisions. The number of mentally ill people in the community who are not receiving adequate treatment has increased as a result of deinstitutionalization without a corresponding development of community-based mental health services. At the same time, additional restrictions have been placed on involuntary commitment. Let's look first at deinstitutionalization. The deinstitutionalization of state mental hospital populations beginning in the 1960s was developed in response to a number of factors: legal advocacy on the behalf of people who were warehoused in state mental hospitals, in some cases for a lifetime, the development of more effective psychotropic medications promising better symptom control, and federal legislation establishing community mental health centers to help released patients establish new lives in caring communities. In response, state governments dramatically accelerated the release of patients and the downsizing of state mental hospitals during the 1970s and 80s. The transfer of formal hospital patients to community care represented an important effort to provide new opportunities for integration in community life, as well as more humane and cost-effective care for people with mental illnesses. Unfortunately, planning was flawed, and implementation uneven. One major problem was the failure to anticipate and address the not in my backyard syndrome that soon developed in many communities. In some places, local neighborhood organizations fought attempts to establish group homes. Local mental health systems struggled to provide an adequate array of services, but were generally unprepared to meet the basic needs of a population that had long been dependent on institutional care. Due in part to communities' lack of preparedness and resources, the needs of many of the deinstitutionalized individuals have not been met. As a result, growing numbers of released patients drifted toward life on the streets, and many of them have ended up exchanging hospitalization for institutionalization in prison or jails. Second, let's look at reductions in treatment and spending and availability. While treatment enables many people with serious mental illnesses to function effectively in community life, access to treatment and other essential services often falls short of the need. Barriers to treatment include fragmentation of treatment services, homelessness, lack of transportation, and difficulties in accessing key government-funded health coverage and income supports. State governments have traditionally been the major funders for public mental health services and remain so today. But according to the Basel and Center for Mental Health Law, Total state spending for treatment of the seriously mentally ill is 1/3 less now than in the 1950s. According to a 1998 study by the Center for Mental Health Services, a division of the Substance Abuse and Mental Health Services Administration, a comprehensive analysis of nationwide spending on mental health, alcohol, and drug abuse treatment services found that the growth of spending for the treatment of mental illnesses and substance abuse has been lower than that for health care generally. Long-term hospitalization in private mental health facilities has also declined due to cost increases, restriction on insurance coverage for mental illnesses, and time limits imposed by insurers on length of inpatient treatment. The third issue is barriers to involuntary commitment. Families and others seeking to force the mentally ill into treatment are faced with changes in mental health law that have made involuntary commitment more difficult. Most state mental health codes require psychiatric hospitals to show clear and convincing evidence that patients being committed involuntarily are either a danger to themselves or others, or are so gravely disabled by their illnesses that they are unable to care for themselves. People cannot be hospitalized against their will without legal representation and a full judicial hearing. Some critics of these laws have called for a relaxation of commitment standards so that the individuals who are mentally ill that are not receiving treatment can be returned to hospital. However, laws regarding both involuntary treatment and involuntary commitment are controversial, and advocacy groups and service providers working on behalf of the individuals who are mentally ill are deeply divided on them. The final issue is the criminalization of mental illness. Police, courts, and legislatures have adopted an increasingly punitive approach to the treatment of people who do not fit within societal norms. Policies such as zero-tolerance policing, mandatory sentences that carry harsh penalties for drug offenses, and restrictions on access to support systems such as welfare are all reflections of the punitive rather than problem-solving approach, which has led to the criminalization of individuals who have a mental illness. Criminalization implies that people are being inappropriately processed through the criminal justice system rather than through the mental health system. However, if people with mental illness commit serious violent crimes, then a criminal justice response may be necessary in order to preserve public safety. Studies suggest that the crimes committed by individuals who have a mental illness fall under three broad categories. First, illegal acts, which are a byproduct of the mental illness. For example, disorderly conduct, criminal trespass, disturbing the peace, or public intoxication. Second, are economic crimes to obtain money for subsistence, for example, petty theft, shoplifting, and prostitution. And the third category is more serious offenses, such as burglary, assault, and robbery. Offenses in the first two categories might be avoided or at least reduced by better community resources, providing treatment and other support services. Crimes in the third category are likely to continue to involve the criminal justice system. However, individuals with a mental illness in prisons and jails need treatment and services to ensure that their condition is not exacerbated by imprisonment. They also require specialized pre-release planning to ensure a successful transition back into the community. The revolving door between jail and the street is propelled largely by untreated mental illness and co-occurring substance use disorders among individuals who have committed relatively minor crimes. This population includes homeless and individuals who have a mental illness whose untreated mental illnesses lead to repeated nuisance crimes in jails. People with a mental illness are more likely to exhibit the kinds of behaviors that will bring them into conflict with the criminal justice system, particularly under current policies of zero tolerance and arrests for quality of life crimes. According to the Bureau of Justice Statistics, prisoners with mental illnesses were twice as likely as other inmates to have been homeless prior to their arrest. 40% were unemployed, and nearly half said they were binge drinkers. Many people who suffer from both mental illness and substance abuse are particularly at risk of incarceration. Estimates of the proportion of people with mental health disorders who also have a substance use disorder range between 25 to 50%. Almost 60% of mentally ill state prisoners reported using drugs in the month before their arrest. Co-occurring disorders in particular are strongly associated with poor social functioning, homelessness, violence, arrest, and incarceration. The population of individuals with substance abuse problems, as well as mental health problems, is considered hard to serve and is chronically underserved in most communities. Some providers are unwilling or unable to work with persons whose illnesses are so difficult to manage. Hospital emergency rooms, homeless shelters, and jails are often used as de facto service centers for troubled, indigent, and vulnerably mentally ill substance-abusing individuals. An overloaded system and the lack of adequate treatment resources for co-occurring mental illness and substance abuse disorders have severely restricted many individuals' access to treatment, increasing the likelihood of offending and incarceration of these individuals. SAMHSA has published a guide for services for justice-involved individuals that list 8 principles for serving this population. We'll discuss each of those principles. Principle 1 states that community providers should be knowledgeable about the criminal justice systems. This includes the sequence of events, terminology, and processes of the criminal justice system, as well as the practices of criminal justice professionals. The criminal justice process starts at the point of contact with a law enforcement officer. Such contact may result in an arrest and entry into the criminal justice system, including prosecution, pretrial services, adjudication, sentencing, sanctions, and corrections, the last of which may involve jail, prison, or community supervision. Understanding the criminal justice system can help community providers facilitate continuous and coordinated treatment and services for justice-involved individuals with mental health and substance use disorders. This understanding also helps providers know where in the criminal justice system and with what criminal justice personnel their client is currently involved. Understanding the system also helps community providers recognize where opportunities exist to divert clients into treatment and services both before and after entry into the criminal justice system. Principle 2 states that community providers should collaborate with criminal justice professionals to improve public health, public safety, and individual behavioral health outcomes. Collaboration between community providers and criminal justice professionals is essential for ensuring continuity of care and care coordination during transitions to and from incarceration, and sustaining treatment and supports both in correctional settings and in the community. This includes sharing information, responsibility, and accountability, clarifying roles and responsibilities, ensuring treatment and supervision efforts are complementary, and working collaboratively with individuals to identify and meet their treatment and supervision goals are the cornerstones of an effective partnership. For individuals under the supervision of community corrections, partnering with parole and probation professionals can facilitate coordinated care and adherence to supervision requirements. Principle number 3 states that evidence-based and promising programs and practices in behavioral health treatment services should be used to provide high-quality clinical care for justice-involved individuals. Evidence-based programs and practices for mental health and substance use disorders should be used for all individuals, with adaptations specific to justice involvement when appropriate. Adaptations include practices that specifically address criminal thinking through cognitive skills training focused on judgment and criminal behaviors. Treatment should be tailored to the individual and address motivation, problem solving, skill building to improve cognitive, social, emotional, and coping skills, and assist in building pro-social supports and activities. Where needed, integrated treatment for co-occurring mental illness and substance use disorders should be provided to ensure coordination and continuity of care. As with all clinical care, community providers should track treatment outcomes and adjust treatment as needed. Principle number 4 states that community providers should understand and address criminogenic risk and need factors as part of a comprehensive treatment plan for justice-involved individuals. Criminogenic risk is the likelihood that an individual will engage in future illegal behavior in the form of a new crime or failure to comply with conditions of probation or parole. Criminogenic needs are factors that increase an individual's likelihood of reoffense, such as lack of employment or livable wages, or the presence of a substance use disorder. Criminogenic risk and need factors are malleable and responsive to intervention. Research indicates that behavioral health treatment alone does not reduce recidivism, and conversely, interventions that address only criminogenic risk and need factors do not improve behavioral health outcomes. Effective treatment for justice-involved individuals includes evidence-based and promising programs and practices that address an individual's mental illness, substance use, and the criminogenic risk and need factors. Principle number 5 states that integrated physical and behavioral health care is part of a comprehensive treatment plan for justice-involved individuals. Formerly incarcerated populations are at increased risk for serious and complex chronic health conditions and may require coordinated care with other healthcare professionals. Rates of infectious and non-communicable chronic diseases are high in incarcerated populations and those under community supervision. Furthermore, incarceration may exacerbate these existing medical conditions. Testing for infectious and non-communicable diseases and coordinating medical service are part of an effective plan for justice-involved populations. By integrating physical and behavioral health care, community providers can offer whole-person care that is well coordinated and convenient for an individual, thereby improving access to and engagement with the services. Where needed, this should include integrated treatment for co-occurring mental and substance use disorders. Principle number 6 states that services and workplaces are trauma-informed to support the health and safety of both justice-involved individuals and community providers. justice-involved populations have high rates of exposure to traumatic events. Individual trauma results from an event, a series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. While incarcerated, individuals may experience trauma specific to the jail or prison setting, including sexual violence, physical violence, intimidation, confinement, isolation, and coercion. Prior trauma may be compounded by experience of trauma while incarcerated. Creating and promoting a trauma-informed approach to services in the workplace promotes safety and trust and can minimize risky situations in office or field-based settings for both the client and the practitioner. Trauma-informed approaches include consideration of the safety and well-being of all persons involved, including both the clients and the providers. Principle number 7 states that case management for justice-involved individuals incorporates treatment, social services, and social supports that address prior and current involvement with the criminal justice system and reduce the likelihood of recidivism. Individuals currently involved with the criminal justice system or re-entering communities from jails and prisons face unique obstacles in finding housing, employment, and coordinating health and behavioral health care. Case managers play an important role in connecting individuals to services and addressing social factors that can contribute to low quality of life, poor health, and recidivism. These include lack of housing, employment and vocational activity, and social supports from peers or family members or both, and untreated substance use disorders. And finally, Principle 8 states that community providers recognize and address issues that may contribute to disparities in both behavioral health care and the criminal justice system. Different population groups, often based on race, ethnicity, gender, sexual orientation, and economic status, have disparate access to high-quality behavioral health treatment and experience disproportionate representation in the criminal justice system. It is important for community-based providers to understand these structural biases in order to prevent their further perpetuation and interference with positive treatment and justice outcomes. Our next special population is individuals who are homeless. There is no typical profile for persons experiencing homelessness. The person could have recently lost a job, left jail or prison. It may be someone without money for rent, or a young person recently kicked out of their family. The numbers are staggering. An extensive survey conducted in 2015 found 565,000 people who were homeless on a given night. While 69% of those individuals were in some type of shelter, 31% of them, or 175,000 individuals, were unsheltered, living on the streets, in vehicles, or in abandoned buildings. 250,000 of these individuals had a mental illness, and 140,000 of them had a diagnosed serious mental illness. Poverty predisposes people to homelessness through a range of environmental factors. 5 to 10% of people who are poor experience homelessness in any given year. Since the 1970s, vulnerability to homelessness has increased among the poor as access to affordable housing, social safety nets, and adequate income have decreased. For example, housing costs price many people with below poverty incomes out of the market. More than 14 million families have worst-case housing needs, defined as spending more than 50% of their monthly income on rent. The removal of institutional supports, for example, deinstitutionalization, has resulted in fewer housing options for people diagnosed with a serious mental illness. It is critical that housing issues be addressed in disposition planning when individuals are discharged from inpatient or outpatient mental health or substance abuse treatment settings. Clients leaving intensive treatment settings who do not have adequate housing to support their recovery have a significant higher risk of relapse. And finally, decreased job options for people with high school educations and increasing disparity between minimum wage and cost of living have made it increasingly difficult to earn enough money to afford housing. Environmental factors affecting vulnerability to homelessness directly relate to community resources. Community solutions for preventing homelessness and ending chronic homelessness include affordable housing, access to permanent supportive housing for clients with mental illness or substance use disorders, improved schools, training, prison transition programs, job opportunities, and support service. In addition to substance use and mental health disorders, a range of complex interrelated individual risk factors are also related to homelessness, including trauma-related symptoms, cognitive impairment, medical conditions, lack of support from families, limited education, job skills, and incarceration. A significant percentage of individuals who are homeless will likely experience one of these issues. For example, veterans who are homeless report that 3 aspects of their service contributed to their homelessness. Substance abuse, beginning in the military, was true for 75% of the individuals surveyed. Inadequate preparation for civilian employment, which affected 68%, and loss of structure, also affecting 68%. People who have or have had mood disorders, schizophrenia, antisocial personality disorder, or any substance use disorder are at least 2 times more likely to have been homeless than those without these diagnoses. Of people who are homeless and in substance abuse treatment, 68% of men and 76 to 100% of the women report trauma-related events, which are similar rates to those reported by general samples of individuals who are homeless. As many as 80% of people who are homeless exhibit cognitive impairment, which can affect their social and adaptive functioning and their ability to learn new information and new skills. People who are homeless have high rates of HIV and AIDS, hepatitis C, cardiovascular conditions, dental problems, asthma, diabetes, and other medical problems. Lack of familial support increases the risk of episodic and chronic homelessness and manifests as disconnection from family, childhood placement in foster care or other institutions, and childhood physical or sexual abuse by family members. 38% of people who were homeless and received services lacked a high school diploma or equivalent. And finally, incarceration is common among people who have experienced homelessness. 54% 4% of the individuals surveyed. Many individuals leaving prison have no place to live and seek housing through community resources for homelessness. To provide effective services to people who are homeless or at risk of becoming homeless, behavioral health workers should possess knowledge of a number of areas. First, they should possess knowledge about homelessness, its impact on people and family, how it acts as a barrier to services for other problems, such as substance abuse and mental illness, and how, without intervention, it can become self-perpetuating. Second, we should have knowledge of how substance abuse, mental illness, and homelessness interact to limit clients' opportunities for growth and change. Third, we should understand the medical comorbidity in the homeless population and how to help people address physical wellness. Fourth, we should understand the pervasiveness of physical and sexual trauma within homeless populations and the effects of trauma in limiting opportunities for recovery from mental illness and substance abuse. Fifth, we should understand the effects of the experiences of incarceration among individuals who are homeless. Sixth, we should understand local homeless assistance services and available community resources and how to help clients with a mental illness or a substance use disorder access them. We should understand the process of recovery from substance abuse, mental illness, and homelessness, including appropriate interventions at different stages in recovery. Also, the interaction of co-occurring substance use and mental disorders and homelessness. We should recognize prevention and treatment methods that have been shown to be effective or promising with people with substance abuse or mental illness who are homeless. We should understand the fact that having a substance use disorder or mental illness can itself affect the process of relationship development and trust in others. The following skills will allow us to be more successful in working with clients who are experiencing homelessness or the threat of homelessness. We need to use techniques for creating trusting, collaborative relationships with members of a population that experiences high rates of social disaffiliation, for identifying client strengths, and for helping clients empower themselves to initiate and sustain stable housing and recovery. We want to demonstrate specific outreach skills for people who are homeless, particularly those who are chronically homeless and have substance use or mental health disorders. We need to conduct an initial screening and needs assessment for clients who present with substance use or mental health disorders and are homeless or are facing homelessness. We need to recognize the effects of psychological trauma on trust, on the willingness to persevere and accept help from others, and a variety of other personal and interpersonal dynamics that are important in treatment and recovery. We want to support clients' early changes, for example, entering treatment, recognizing and addressing their mental health and substance use disorders, finding temporary housing, obtaining medical care, finding some financial support. All of these early changes need to be recognized and rewarded. We also want to develop person-centered treatment or service plans that consider the whole person and his or her individual needs, including early intervention for emerging mental and health and substance abuse problems, mental illness and substance abuse treatment and rehabilitation, and programming to build resiliency and enhance quality of life by developing social and occupational skills. We use case management skills in helping people make contact with and continue to access needed community resources, including prevention programs. We want to work to retain clients in treatment programs by maintaining rapport, motivation, and hope, and by helping them work through the obstacles they face in their recovery process. We develop realistic, individualized relapse prevention and recovery management plans that include specific steps to follow if a client experiences a recurrence of behavioral health symptoms, homelessness, or other life problems. And finally, we want to collaborate with other service providers, family members, and social supports. This collaboration helps people who are homeless access services. It helps us to better understand their individual needs and strengths, and it helps to ensure appropriate care and smooth transitions between different levels of care. In addition to the previously described skills, a certain set of attitudes also is an assistance in working with individuals who are homeless. Behavioral health workers engaged in providing services to clients who are dealing with homelessness can benefit from the following attitudes. First, accept and understand powerful emotional responses to client behavior and address these responses in supervision. As a precondition to a positive working relationships, we want to meet clients where they are rather than where they should be. We want to appreciate that people must assume responsibility for their own recovery trajectories, although they sometimes make choices that do not appear to be in their own best interest. Trust that change begins with small steps that are self-reinforcing and aggregate to larger changes. Understand that all change is incremental, and that many clients who are experiencing homelessness are on a long recovery pathway. Recognize that consistency and reliability can counteract the disaffiliation and mistrust experienced by many people who are homeless and have substance use or mental health disorders. And finally, appreciate that work with people who are homeless and in need of treatment requires collaboration and cooperation among a range of service professionals and peer supports. Engagement is the first and perhaps most critical stage of work with people who are homeless. Its goal is to facilitate the individual's movement through the early stages of behavior change. Approaches during this phase include active outreach to prospective clients and engagement services, including capturing prospective clients' interest in a variety of homeless services, as well as substance abuse, medical, mental health, and other social services, gaining the prospective client's trust and increasing the individual's motivation for change. For families who are homeless, the prospect of preventive services for children may be especially attractive. During this engagement process, we should identify and attempt to meet the basic needs for shelter and safety, and we should also attend to any immediate health concerns. For some persons who are homeless, for example, those coming from criminal justice settings or those being discharged from treatment programs, outreach may not be a particularly difficult issue, but engagement in social, health, and continuing services may present more of a problem. Persons with transitional homelessness may not perceive the need for additional services beyond lodging, seeing their stay in the shelter or other homeless housing program unrealistically as a temporary transition to getting a place of their own. Additionally, clients recently in treatment for mental health and substance use disorders may not recognize the effect of their impending homelessness on substance abuse and mental health recovery and across all other aspects of their lives. As behavioral health workers, we can play an important role in outreach by acknowledging homelessness as a significant element in when and how people can access treatment, by recognizing the needs of people who are homeless for preventive and basic services, and by developing productive, trusting, and supportive relationships with people who are homeless and approach us for services. Outreach plays a crucial role in working with people who are experiencing homelessness. It means making contact with individuals on their terms, where they live, rather than in an agency setting. It involves developing sufficient trust to help people consider receiving services and the benefits they may accrue from those services. It may well mean developing rapport with people who, because of their experiences, have no expectation of a positive outcome. Outreach is particularly relevant to the engagement stage of homeless rehabilitation. It involves deliberately and methodically cultivating a relationship with the person or family who is homeless. Effective outreach skills include expressing appreciation for survival skills as strengths and coping mechanisms, understanding substance abuse and or psychological symptoms from the client's perspective, and understanding how these symptoms are interrelated, addressing financial and health benefits as well as food, health care, housing, and other immediate needs, expressing optimism that together we can create a plan that meets the person's needs, and empowering the client to set goals and create a plan for recovery and growth. We will probably find that outreach efforts with people experiencing homelessness are more aggressive and proactive than those we use in traditional settings. We may find ourselves meeting our clients literally where they are, rather than waiting for them to come to us. While taking care to respect people's autonomy, we may be more assertive in engaging people into services. We may find ourselves responding more actively in crisis situation or becoming more involved with that individual than we might with other individuals that we serve. In effect, the skills of outreach are generic, but how we apply those skills may be different with individuals who are homeless than how we apply them in our traditional role. This completes our lesson on the needs of special populations. Please remember that you must complete the attached quiz with at least a score of 70% in order to complete this lesson. Good luck, and thank you.